laparoscopic greater curvature plication, initial results of an alternative restrictive bariatric procedure.
Mr. Chairman, Mr. Moderator, thank you. It's a pleasure to us to stay here, and we really think if so to allow us to present this, what it seems a very interesting procedure that could, if improved, its safety and efficacy using our armamentarium. Try to unfold with your graspers the greater curvature in order to have some picture of what your procedure is going to be after the suture. And on that series that you can see here, with one grasper infold in order you to make sure that your suture gonna take the posterior and anterior wall of the greater curvature, as you can see here on this following. And then you have some suture, 8 to 10 sutures of interrupted braided marceline edge bone. So this will serve as a guide to come with a running suture from top to bottom, from the his angle to the antrum, in order to create a sleeve-like shape that at the end looks like a 40 to 60 French bougie sleeve shape, as we can see here. Endoscopy shows us a very, very big fold of the greater curvature. I'll drive you guys here. This is small curvature, my arrow. This is greater curvature, anterior wall, posterior wall. And 10 days endoscopy, and expect even worse up to 1 month, because they have a lot of edema and venous stasis. And just after 1 month, it seems like it dries out. I don't know if it's the exact term in English, but the edema goes, and you have the impression that your sleeve is dilated, but it's not. It's the shape that you're gonna have up to what you have in the later weight loss total. So the variety was ranging from 42% to 90+% of assessed weight loss. As a wide range of variation. So we don't have at that time enough follow-up to assure you.
The ring patients lose, band patients lose over a 3-year period. So what you are really reporting is an interval report. They have not reached their lowest point. So we don't know if they're going to lose too much or too little. The 10% is not very good, and the 90%, maybe we should be a little worried. We don't know though.
We don't know yet, and we'll agree with you. That's why we are its initial results reports.
We're going to take 2 more questions for the sake of time. Yes, sir.
Now, you know, we started doing this procedure a few months ago. Now we have the experience of 22 cases. And my question is, what are your criteria of the correct tightness of the plication? How do you understand that the plication is not too tight or too loose?
$1 million question. We don't know. It relies on a lot of fine-tuning from the surgeons. And the industry, we are pursuing a way to standardize this, because if you are too, how can I say, happy with the procedure, you can go more than necessary. So we have some reports of blockage that needed to take out 1 or 2 sutures. And it's still a fine-tune that you were already getting as cases is going. But I think that the industry is thinking a lot in how to address that. There are tools in the market now that can make you sure that you're doing the correct stitch, and they guarantee, or not guarantee, but they give you a very good idea of what the lumen you have, and that is really more sophisticated than just have a bougie inside. And if you guys are concerned about that, just use a larger bougie, but we don't know about the results.
Last question, please.
Dr. Pujol from Barcelona. Excellent work. I think it's a technique that it's very, a priori seems very attractive for substituting sleeve gastrectomy. But there are 2 options, the anterior plication and great curvature plication. It seems easier to doing the anterior plication. Why? My question is, why did you decide to do the greater curvature application?
Well, that's a nice question, but I'll left Dr. Stacy to comment that, because they ran a prospective trial comparing anterior and posterior. They're going to show you why we all are jumping on the way to cover. They have really reliable data that you can take advantage of. Just let Dr. Stacy on this presentation too, if you just wait for.
Sure. Hopefully I'll answer your question with my last talk.